Welcome to the Mom and Mind podcast. I'm your host, Dr. Kat. I'm very honored to welcome on Dr. Samantha Meltzer-Brody. She is going to be sharing information with us regarding the new postpartum depression medication with the brand name of Zurzuvae, or Zuranalone, which was recently approved by the FDA. This is the first pill for postpartum depression, which is different from the IV infusion Braxanalone for postpartum depression, which was approved in 2019. She's going to share with us what to know, what we don't know, and how fantastic it is to have another tool in the toolbox for treating postpartum depression. Dr. Samantha Meltzer-Brody, MD, MPH, is the Assad Meymandi Distinguished Professor and Chair of the Department of Psychiatry at the University of North Carolina at Chapel Hill. She is an internationally recognized reproductive psychiatrist and clinician-scientist who also directs the UNC Center for Women's Mood Disorders. Her work has focused on developing a comprehensive integrated clinical and research program in women's mood disorders across the reproductive life cycle. She investigates the epidemiologic and biological predictors of perinatal depression, including genetic, neurosteroid, and other neuroendocrine biomarkers, as well as the impact of adverse life events. I'm really happy to have this conversation with Dr. Meltzer-Brody so soon after the medication was approved by the FDA, because there are so many questions that people have. And I think it's really useful just to know what we know so that we can also stay ahead of any questions, misinformation, or worries that people might have about medication. And just know that with any new medication like this, certainly it's going to bring up a lot of questions for people. So I'm happy to have her on and answer the questions that I know some of you are already having. So let's welcome Dr. Meltzer-Brody. Welcome, Dr. Meltzer-Brody. Thank you so much for taking time out of your very busy schedule to come on and explain to us about this new medication for postpartum depression.
It's a pleasure to be here, and thank you for having me.
Sure.
So the new medication that was approved by the FDA last week is called Zuranalone, and it is a positive allosteric modulator of GABA. It is very much similar to Braxanalone, which was approved in 2019 as an IV formulation to treat postpartum depression. Braxanalone is a proprietary formulation of allopregnanolone. Zuranalone is modified a bit to make it more stable as an oral drug. So it is not just an oral form of Braxanalone. It's a little bit different, but also a positive allosteric modulator of GABA. So GABA is the main neurotransmitter system involved. And
yeah. So for people who are listening, who are kind of new to those kinds of words, if like I guess a layperson's explanation of what that is and what that means.
Right. So what's exciting about Zuranalone is that it is a treatment that is based on a hormonal hypothesis. And so we know during pregnancy that estrogen and progesterone in all pregnancies rise rapidly, and they then fall quickly at the time of childbirth. That's normal physiology for anyone that's pregnant. And allopregnanolone is the main metabolite of progesterone that crosses the blood-brain barrier, called a neuroactive steroid. Neuroactive meaning impacts the brain, and it's a steroid. And allopregnanolone has been studied for quite a while and was suspected of having powerful antidepressant effects and also anti-anxiety effects. And so Braxanalone, which was developed as a form of allopregnanolone, it's a finicky compound, and it was delivered in IV. And that's something that has been used. You have rapid onset of action. So that's the main thing that's really exciting about this class of drug, is rapid onset of action. But an IV drug is obviously not convenient. So Zuranalone is an oral form. It is modified a bit. It's very similar to Braxanalone, also a neuroactive steroid. And it's also rapidly acting. So this new drug is an oral drug. It's rapidly acting. You have onset of action beginning at day 3 in the clinical trials. It's given for a 2-week period of time. And then the results were sustained out to day 45 in the clinical trials. So
that's very promising.
Right. And now we don't know what happens after day 45. And that will be something that will be an important area of study moving forward. But what we know now is that it is rapidly acting and it acts very quickly. And that is, I think, a huge innovation in treating depression, and that it was effective in the majority of women in the studies that took it.
That's fantastic news. And I know that when Braxanalone came out, it was very exciting. And also, yes, there were a lot of barriers to that because of the IV administration. So having this pill form obviously makes it more accessible. And I want to get to some of the questions that I know people have about this medication in just a little bit. But if you could explain a little bit of the difference between the medications that are used now and have been used for some time for treating perinatal mood disorders like SSRIs, and how that is a little or very different than this new medication.
So they're completely different mechanisms of action. So the SSRIs were approved in the late 80s and early 90s and are effective antidepressants. They have a large body of evidence. They were never developed specifically for postpartum depression. They are the selective serotonin reuptake inhibitors. Fluoxetine, which is Prozac, was the first one that was approved in the late 80s. And they have been studied. In particular, there's been clinical trials, small studies that looked at the effect of sertraline or Zoloft on treating postpartum depression, and it is a helpful antidepressant. We have all used the SSRIs as mainstay for antidepressant treatment for decades.
Right.
And they were revolutionary at the time when they were approved because you could use them and they were much safer in terms of side effects and risk of overdose. So the previous antidepressants that were commonly used, the tricyclics and the MAOIs, had significant side effects or had significant risk of potential overdose. And so that was made them, was a major downside, frankly, to people using them. The SSRIs had fewer side effects and were much safer to give. And actually, one of the things that's most remarkable is that the ability to have non-psychiatrists prescribe them, primary care doctors prescribe them, OBGYNs prescribe them, led to many more people receiving treatment for depression that required medication therapy or needed medication therapy. But they take 4 to 6 weeks to work or longer. For some people, they're not effective, a sizable number actually. And there are significant side effects, namely concerns about sexual dysfunction, potential with weight gain, or other side effects, GI side effects that make them something that some people don't want to take. And so I think that my interest in being able to participate in clinical trials with a novel compound, that there was a need for innovation and a need for new tools in the toolbox.
It's been a long time.
Been a long time, and you can't have just sort of one class of drug that you hope that most people are going to respond to when we know that a significant portion are not. So the allopregnanolone hypothesis, the hormonal hypothesis of postpartum depression, has been compelling for a long time. And that is what led to the interest to begin studying allopregnanolone as a treatment for postpartum depression. Again, Braxanalone being a proprietary formulation, but an oral drug that's very, very similar, also a neuroactive steroid that acts on GABA. So if the SSRIs impact the serotonin system, this new class of drugs, positive allosteric modulators of GABA PAMs, impact the GABA system. They are different than benzodiazepines that also impact GABA. The new drugs, they hit both intra and extrasynaptic receptors, which is different than the benzodiazepines. And that's why you see a different mechanism of action. So the benzodiazepines are not antidepressants.
Right. Those are like the Xanax, Ativan.
Valium, yes. this class of drug has a different mechanism of action than that. Also GABAergic, but different mechanism of action, and they are clearly antidepressants. You also see the anxiolytic effect, the anti-anxiety effect, and the primary side effect is sedation, which would also be expected. So with Zuranalone, one would expect that people will take it at night or then go to bed. And the FDA approved it with a warning about sedation and certainly warning against driving at night. Now, most people you hope will take it before to go to bed, and they're not going to be planning on driving.
Right.
And the degree of sedation can markedly vary depending on the individual.
Right. So this is, you said daily for 2 weeks. A medication.
Yes, it's been studied. It's been studied as being daily for 2 weeks. That's 15 days in the clinical trials. And then at the end of that, it was stopped, and then patients were followed for 45 days of the clinical trial.
Okay. So what do we know from the clinical trial in terms of how it impacts depression in the postpartum and results, I guess, or what has been seen from the studies in terms of how people are responding to it and for how long, I guess, up until that 45-day mark?
So in the 2 clinical trials that were done, the phase 3 clinical trials, the first one, the Robin study, was published a few years ago in JAMA Psychiatry, and the second paper for the Skylark study was published last week in the American Journal of Psychiatry. And my terrific colleague, Dr. Christina Delingianides, is the first author on both. I'm the second author.
Amazing.
And she provided tremendous leadership throughout the clinical trials. In both studies, you see a high response rate of study participants, that it was well tolerated, that the majority of women had responses. Both studies, you see significant onset of action and reduction in symptoms beginning at day 3. And then you see by the end of the first week, people generally have had marked response and or remission of symptoms that then persists at day 15 and then persists out to day 45. So
fantastic.
That's what we know from the clinical trial data to date.
Right. Oh, okay. So that's very promising news for sure. And you already listed some of the potential side effects, and you said just now that it was pretty well tolerated, even with the drowsiness.
Yes. So the main side effects are sedation and sleepiness and dizziness. Those are the primary side effects that were observed in the clinical trials. And for that reason, people will need to monitor sleepiness levels. Some people are going to feel that more than others. You can have dose adjustments, but most people will be taking this at night. But certainly, if a mother's taking it and then needs to be caretaking for the baby at night during the course of treatment, you're certainly going to want to make sure, ideally, that you have someone else that can help you during that period of time.
Right. So this is what I've already started to see in social media and questions about, well, what about a mom who needs to be up at night with the baby? What about nursing, and what about cost? So I'd like to kind of walk through some of those questions about what's known now and what we still need to figure out with time.
Well, I can talk, certainly. And so I have no idea what will be done with the pricing of it. So that is a question for the pharmaceutical company. I'm not involved in that at all. For that matter, I had no idea what it was going to be named as its, commercial name. I know it as Zuranalone, and before that it was Sage, a Sage number. So I think that we will see how it's priced. I hope it will be priced in a way that will make it as accessible to the largest number of women that are interested in taking it. When anyone's suffering with postpartum depression, you hope they have more supports, and that for a 2-week period of time when people are taking it, that they can have some help, whether that's family, friend, whoever that can help with care of the baby until someone's feeling better, or until at least you know how someone's dealing with the sedation of the medication.
Sure.
So at least for a few days, you'd want to know how someone's reacting and figuring out how that goes. But,
yeah,
in general, for someone that has postpartum depression that is in need of treatment with a medication, you are probably dealing with more moderate to severe symptoms. So first line treatment, as we know, that would be recommended for more mild, moderate symptoms is psychotherapy. And so if someone is now considering taking or being prescribed an antidepressant of some kind, one imagines they're having more moderate to severe symptoms, and that's why that's being prescribed, or they didn't have access to psychotherapy for whatever reason, or whatever patient preference may be. And so I think people have to make it a priority to take care of themselves and to get the support around them as needed, to try and get some help during the time they're taking this medication. Again, it's shorter term, but also for someone that's starting any new medication and probably needing some extra sleep and support, it's a good idea to have that.
Right. I mean, at this point, postpartum, who's not needing extra sleep and support? Everybody does. But to your point, like not everyone has all of that access to all of the resources, but really getting what you can where you can is necessary, especially with potentially trying a new medication like this. Some of the other questions I've seen and people's concerns are related to nursing and breastfeeding, and what is known so far about the, I guess, quote unquote, safety of this medication for breastfeeding.
So we know that so far, there's about 1% of the drug is transmitted into breast milk, and that you will certainly need to have more safety data over time. There's nothing at this point that makes it absolutely contraindicated. I think it's important to keep in mind that during pregnancy, you have extremely high levels of allopregnanolone naturally occurring during pregnancy. And so the baby has been bathed in that. Again, Braxanalone, proprietary formulation of allopregnanolone, and Zuranalone is slightly modified, similar class of drug. So safety and data will be forthcoming, but there's nothing that's sort of absolutely contraindicated. It would need to be discussed. I think that every person needs to have a conversation. There's nothing that we know right now that would make it absolutely contraindicated. Some people may want to pump and dump for a period of time, if they really want to make sure there's no transmission at all. But it's a very small amount that we know that's transmitted into breast milk.
Can you give a percent comparison between, let's say, Zoloft, which is regularly prescribed as and thought of to be the, again, quote unquote, safest medication for nursing, the percentage that gets through breast milk to the percentage of Zuranalone, if that makes sense?
Yeah, I mean, I think that the data certainly for Zuranalone is very new. And sertraline and Zoloft, particularly in lactation, has been around for decades. So you're not going to get the same kind of comparison at this time. We know that the data on sertraline Zoloft, generally at doses less than 100 milligrams, you have minimal transmission into breast milk. And I think that you'd want to look at a wonderful resource like LactMed, which will summarize all the sertraline data. For Zuranalone right now, we know that there's about 1% transmission into breast milk. Again, a very small amount.
Very small, yeah.
So I think, again, as more data comes out, and I really rely on independent sources like LactMed to review these things carefully and make assessments, that will be an important thing for everyone to consider. And so, again, these are all very personal choices. And every person that's considering taking any medication has to do an assessment of risks, benefits, et cetera, to see whether something's a good choice or not. I certainly think that the rapid onset of action is going to be what I see as a game changer
Yeah.
for people suffering. So when I'm seeing someone suffering tremendously, and I'm thinking about starting an antidepressant treatment, something that could have rapid onset of action. And if you ask most women, would you like something that can start working within 3 days?
Yeah.
Or would you wait 4 to 6 weeks or longer as we try and titrate something up?
Right.
That's going to be a personal decision that the individual will need to make.
Right. Yeah. To your point, I think what you were saying earlier about medication, obviously, first line is support and therapy, and then considering medication, unless it's a personal preference. But in the study, and what you know of it now, is the medication kind of intended for severe depression, or are there any what's the word, metrics, I guess, about how severe depression needs to be to consider this medication?
Well, at this point, what we know is the clinical trial data, and that is the data at hand. So that was studied in women that had more moderate to severe depression based on Hamilton depression scores. And that's where you see the effect. So that's the data we have now. I think that for everyone, a decision to take a medication would be on a major depressive episode that is markedly impairing functioning.
Right.
So this is not meant to be for women with mild symptoms. I think that this would be people for whom they would say, I meet criteria for a major depressive episode in the postpartum period, and it's causing significant impairment in functioning. And so what we know now is the clinical trial data, which was designed to be people that had, certainly moderate to severe symptoms. And that's where we see the efficacy at this time.
Great. Thank you for that. These are, I'm thinking of the questions that are coming through that I'm seeing on social media and kind of wanting to get, as close to the source as possible in terms of answering these questions, because as I'm sure you've seen, and this happens with everything, is tales sort of start to get spun around what this is and what it means and what it's going to cost, and I won't be able to nurse. And so it's good to know that so far so good, and also more needs to be known.
Much more needs to be known. So I think anytime there's a new medication approved, what you know at that point is the clinical trial data that led to the FDA deciding to approve it. And I have confidence that the FDA is going to do very careful assessment and review, particularly in a drug that is going to be indicated for a vulnerable population of, in this case, postpartum women.
Right.
I think every individual is going to do their own assessment. And there are people that are always going to be like, what you might refer to as early adopters, right? I'm going to be first to the gate. And if I have this, or great, it's going to work within 3 days, sign me up. And then you have other people who are going to want, much more data to be comfortable in things. And everyone is going to have to decide that. So what we know now has all been published, in the 2 phase 3 trials, and then certainly the phase 2 trial before that, but it's all out there and published for people to review, and then for people to have thoughtful discussions with their doctors around what is the best choice for them. I think that for some people, certainly pricing, in whether their insurance will cover it or not, is going to be a key differentiator.
Right.
And we don't know that at this point. And then, people who are concerned about breast milk and any potential transmission of anything. Again, this is something you take for 2 weeks. It's not something you're taking chronically. Those are decisions individuals have to make. And so all of that becomes very, very personal. And I think everyone needs to figure out what is the right path for them, and make thoughtful decisions in discussion with their doctors.
Sure. Right. So also this medication is not studied in pregnancy, and right now is not suggested during pregnancy, again, because there's no data.
There's no data. It's not been studied in pregnancy, and because it's, based very similar to allopregnanolone, a hormonal treatment. I think that would be a whole different can of worms to study. So it has only been studied in postpartum women.
How far out is this actually available to people? And if you know, well, I'll first ask that. Where are we now in the process of this being available?
I do not know. So that, again, as an investigator on the study, those are all questions for the sponsor of the clinical trials, the pharmaceutical company. They have publicly said they want it to be commercially available by the end of 2023. So sometime between now and the end of this calendar year, December, it will be available. If we look and see how long it took from the time it was approved to the time that Braxanalone was commercially available, it was about 3 months. And so whether this will be available sooner or later, I do not know, but they have said it would be available by the end of 2023.
And do you know, I know there are several steps of approval. And while I know you're not the FDA, do you happen to know what hoops are being jumped through to get this out?
No, at this point, as an investigator and an academic psychiatrist, I know what is in the public domain. So it has been approved by the FDA, and then the rest of it will be, in terms of next steps, you'd have to contact the sponsor, Sage Therapeutics, to get that information. I think you're asking really great questions and looking at all the things we know at this particular time. And so for any brand new drug, you know the data that you have available, and you always learn so much more after it's available.
Oh, right. Yes. Yeah, there is still so very much to know. I guess well, what do you think the significance is? And I guess this is in your seat as a psychiatrist. What do you think the benefit is for there to be a specifically named postpartum depression medication?
I think it's incredible that this was studied specifically for postpartum depression and with a specific focus on women's reproductive mental health. In general, there has not been enough investigation of any medication on the market in terms of how it impacts women. There's many drugs approved on the market that were not studied in women, or all women of reproductive age were excluded because of concerns about someone taking it while pregnant or during lactation. And so while the intent is that it would protect people, the reality then is you have a lot of drugs that actually weren't studied ever in reproductive age women and may be less effective, may work differently, may have different dosing. So I think it's tremendous step forward that there's been an investment in studying this for postpartum depression specifically, which you don't need to be convinced is a problem.
Right.
And as a psychiatrist, I'm really grateful to have a new tool in the toolbox. After my entire practice for decades, we've had really very limited tools in treating depression pharmacologically that have novel action. And I'm a huge fan of rapidly acting antidepressants. When people are suffering and I'm sitting in front of them, and certainly in postpartum depression, where it's now an absolute crisis for mom and the family, and you have the time sensitivity around attachment and bonding, it is painful to have to wait to something to kick in. And I think that rapidly acting antidepressants, and from the time we did the first open label infusion with Braxanalone and seeing people respond quickly within 24 hours, that was tremendous. Seeing the rapid onset of response in the clinical trials with Zuranalone, also really exciting. And I think that I hope the path forward. I mean, I hope we will see more and more drug discovery that leads to faster acting antidepressants, so that we can change the paradigm on how people, whether it's postpartum women or everyone else, how we treat depression.
Yeah, absolutely. I guess I have two questions in there. One, can you maybe speak to the difference between, I've heard people ask, well, what's the difference between just major depression and postpartum depression? And why are they different?
Well, that is a complex question. So one of the things up for debate is postpartum depression different than a major depressive episode at any other time in a woman's life? And there is not any one definitive answer to that question. Mm-hmm. There are people that have had multiple recurrent episodes of depression, and they also happen to be depressed in the postpartum period. Mm-hmm. There are people that have been depressed for 20 years, and if you screen them only in the postpartum period, you will find out they're depressed, but it turns out they've been depressed for a long time. Mm-hmm. There are people that have no history of depression and become depressed in the postpartum period. Mm-hmm. So this drug was studied in women that had onset of depression that was proximal to childbirth, late third trimester or very soon after childbirth. And in that population, this drug was clinically effective and has rapid onset of action. So that's what we know so far. I mean, I believe that postpartum depression is many different things. I don't think there's one kind of postpartum depression.
Right.
And I think there's people for whom it is likely to be this hormonal hypothesis likely plays a more prominent role than other things. But certainly if we think about many different disease states, there's not one flavor of it. And an example I commonly give is breast cancer. You can have one type of breast cancer that is very much hormonally influenced. Mm-hmm. Someone will have estrogen and progesterone positive receptors. You have someone that's hormone negative. That's a very different type of breast cancer. And I am certainly not a breast cancer doctor, but the treatment for someone that is hormone receptor positive or hormone receptor negative is quite different. Right. And we know that 20, 30 years ago, everyone sort of got the same treatment and people had wildly different outcomes. Well, that's because we didn't know that we didn't have the specificity to understand that in the way we do now. And that specificity has allowed there to be much improved outcomes in how we treat breast cancer. My hope is that as we learn more, we will get much more specificity around and much more targeted treatments around how we treat postpartum depression and depression in general. Right. That we will figure out what is the right treatment. And we're talking about people who you're talking about medication therapy. So you've already got to that point in the decision tree. Yep. We will get much more specific about who's going to be best suited for what. So if we even think about the Braxanalone trials, the allopregnanolone trials, 70% of women had a positive response. With Zuranalone, it's a bit less than that, but still pretty close to that. Who are the 30% who didn't respond? Why is that? Right. Right. And so really trying to understand and get more specific, ultimately, it's going to come down to likely our biology and both our genetic signature from birth, our life events, if you will, our epigenetic modification of genes turned on and off, the way other parts of our body work, other influences, all the psychological factors that contribute, all the social determinants of health that may influence any individual. We will get hopefully much more specific about understanding that and being able to tailor things. And then you start throwing in all the comorbidity, people that have, significant trauma histories, people that have co-occurring addiction, people that have any number of things. It can get quite complicated. So I think that this is a step forward, and I see this as a new tool in the toolbox, which I think is wonderful. Yeah. But in no way is this the cure-all for everything. And I know I think that there's been some concerns about that, which is, of course, silly, because this is not going to be the cure-all for everything that ails postpartum women. This will be another tool in the toolbox.
Yeah, I'm so glad that you're speaking specifically to that. I imagine that some of the hope for a cure-all is because people are so desperate to for one, as us on the people who are supporting really want to make sure people are getting better as quickly as possible. And for those of us who have suffered, we wish we hadn't suffered as long. And certainly anything new, I think, and if I can say groundbreaking like this, is going to come with that kind of hope and maybe even pressure. So yeah, it's good to temper that a little bit with a touch of reality as well.
Yes, I think that I understand the hope and the enthusiasm, and I get it. And I think that what we know is the data to date are encouraging, and the data to date were encouraging enough, along with a thoughtful review of efficacy and safety by the FDA to lead to approval. And that's the data we have now. And then anytime a brand new drug is approved, you get significantly more data, onward. But
Sure.
I do think that this will be an important new tool, and it's going to work really well for some people and less well for others, which is what we saw in the clinical trials. And we're going to learn a lot more about who those people are, and hopefully get much more specific, and we can tailor treatments better as we get greater understanding. But we still have a long way to go. Right now, there is not any one test you can do that would tell an individual, here's what's going to get you better, and we can hang our hat on it. That would be nice.
Yeah.
But we don't have that really for anything in medicine, other than the closest you can get to it is to have, culture and sensitivity for what antibiotic's going to work best for a particular bug, and to match that around it. But it's really hard for anything, whether it's cancer or heart disease or whatever it may be, to say this is going to be the fix it for every single person that takes it, and you will go forth and it will all be love and light after that. Unfortunately, that's not necessarily how it works for anything.
Absolutely. Because you have seen, I'm sure, some medications come out during your time in psychiatry, do you suspect that there will be more companies, more organizations or whatever trying to let me see how I want to ask this. Do you think this will encourage more trials, more? What have you seen, I guess, in terms of, or what do you hope for anyways?
Well, my hope is that because this is a new mechanism of action, again, a GABA PAM, a positive allosteric modulator of GABA, that it's going to spur on more innovation, both in that area and also other research into novel treatments for depression. That we have really been stuck for a long time pharmacologically, sort of in the serotonin hypothesis.
Right.
You have, a number of drugs that are a little bit different here and there. You have bupropion, Wellbutrin, which is more dopaminergic. But if you look at where we've been, we had the MAOIs, you have the tricyclics, and then you had the SSRIs, or some combination of mix and match of those. So I think that the hope is that this will spur on additional innovation, and that we will see a renewed investment in determining other forms of treatment. And I think also renewal and ongoing commitment to further understanding what are the underlying causes of major depression. It's not going to be one thing. It's going to be a lot of different things. Yeah. And that we understand the underlying pathophysiology better. We understand the biomarker signature better. We understand the intersection between our life events, our social determinants of health, our biology, and that we get better at treating people into both response and remission.
Absolutely.
So that we ultimately decrease suffering. I'm humbled by the fact that far too many people still die of suicide. Far too many people, most women with postpartum depression, are not treated to remission. And I think, to me, that's the bottom line. Most women in this country don't receive adequate treatment, and they are not treated to remission, who suffer from postpartum depression with tragic consequences.
Absolutely.
And so people can, get really worried about one particular aspect or another, but we need innovation.
Mm-hmm.
And we are not always good at embracing innovation. There's
Mm-hmm.
always a lot of fear, which is important. You don't just rush out for what's any
Right.
shiny new thing. But I think having a sort of a good balance of saying this is potentially a great new tool in the toolbox, and then also, and we need to see, what additional data is revealed, but we need innovation in what we do to help decrease suffering.
Thank you, Dr. Meltzer-Brody, for coming on and sharing all this information. I know it's going to help so many people who not only help seekers, but also people who are providing support to have this resource, to be able to understand this a bit more, and have what I really appreciate about what you're saying is this like tempered approach that it's a tool in the toolbox. And just thank you so much for your time and your expertise and all that you do for the reproductive psychiatry world.
Well, right back at you. It's a pleasure to get to talk with you today. Thanks for having me.
Thank you. This interview was so informative, and I'm really glad to have a little bit more information and hear really directly from the people who are closely involved in these clinical trials and who understand the limitations of what we can know at this point, so that we can have our questions answered. And the more information we can have at this point, the better. So please do share this episode as far and as wide as possible. There are so many people who have questions about this, and I know that this information can be supportive. For any of you out there who are needing more support during the postpartum period, I do offer quite a few online courses that are on demand, really easy to move through at your own pace, and you can find them at wellmindperinatal.com/courses. In particular, there's one course that helps you walk through some of the perinatal mental health conditions that could come up during this time for you, to help you decipher what might be going on and how you can seek additional support. Thank you so much for being with us. Until next time.